can see by the picture here, by this rather despondent looking older woman who's just has an assortment of pill boxes, press tabs, and liquids that have all been prescribed. And usually what we know is that older adults on average see 6 different physicians a year. That's just on average across the country. And remarkably, there's about a 2-to-1 ratio of specialists. So older people see specialists more than they see primary care doctors. And so, as you can imagine, there's not much coordination of all these different providers. And a lot of times medications are, as an example, are prescribed for, let's say, benign positional vertigo. And, it's a self-limited disease, usually occurs or resolves itself after 4 to 6 weeks. And yet people are still taking Antivert or any number of medications for this so-called chronic condition. So we want to kind of set it up and understand where we're going, with the concept of chronic disease assessment and management. So we'll first get into the epidemiology here. So if we get to the next slide. The goals today are to try to define what is a chronic medical condition. I often challenge people to think about, different things like, is gun violence a chronic condition, or could it be considered a chronic condition? And a lot of other provocative things about what actually is a chronic illness. We want to talk about the second goal there, which is reporting risk factors for chronic disease. And then we'll talk about some of the assessment tools and management tools that we can use for chronic disease. And then finally, as we move along here, probably in part 2 of the series, we'll talk about more health systems orientation. So some of the emerging concepts that I wanted to share with you is that if we can delay aging, we more than likely can prevent a lot of chronic conditions. And that's one of the studies that has come out now using metformin in non-diabetic patients is exactly trying to address that kind of question, is that can we slow the aging process down? We also know that chronic disease management has 2 different approaches. One is the kind of the face-to-face patient-centered approach, which is a lot of what we're addressing here. But then also, how are we moving the needle for population management? And so we're always concerned about, as a group, how is our population of 65 and older adults doing with their blood pressure control? Are they closer to 120 systolic, or are they closer to 140 systolic? And that has big ramifications in terms of cardiovascular events, longevity, and functional ability. And then the final point is that provider, I use the general term now because, it's not just physician, it's provider reimbursement from Medicare is moving from what we call these relative value units. You get so many incremental reimbursements for the more activity you do. And so we're no longer doing productivity, but rather clinical outcomes. And so there's both incentives and disincentives, penalties, I guess is the word I'm looking for some health outcomes. An example of a penalty would be that if a hospital has a patient return to the hospital within 30 days for the same medical condition or for some similar related medical conditions, hospital doesn't get paid for that second hospital visit. So as you can imagine, there's a general interest from providers in the outpatient arena to be able to do things that would help prevent the rehospitalization. And it turns out if you apply the geriatric 4Ms, there's a pretty good bet that you're going to fulfill that mission of reducing. And you won't eliminate everybody, that bounces back to the hospital, but a good percentage. And just as an example, our geriatricians who are working out of Sanford Fargo, when they take care of patients, they have about an 8% recidivism rate. That means 8 out of 100 patients will bounce back to the hospital within 30 days for those that are hospitalized. Whereas the general practice hospitalist-oriented programs are more like 16 to 21%. So fully 1/3 fewer rehospitalizations as a result of applying these geriatric 4Ms. So I think that's an important thing. If what I call a bean counter, I don't know how you can survive without a geriatrician and a geriatric practice, but that's yeah, well, that's just a whole nother discussion. Next slide, please. So I'd like to have a case here. We have an 82-year-old female was brought to the clinic by her daughter. The mother reports she had a weakness of both legs, and she gradually fell to the ground as she was coming to the clinic. Next slide, please. So she has a history of diabetes type 2, obesity, hypertensive cardiovascular disease, diagnosed with reduced systolic heart function and is considered a New York Heart Association class 2 heart failure. She has osteoarthritis, osteoporosis, history of falls, and she is functionally dependent in bathing. You can see the allergies there, her medications below, our best practice medications for heart failure, systolic heart failure, which include an ACE inhibitor and a beta blocker, which is the metoprolol. Okay, next slide, please. So what kinds of questions do you think we should ask about the history of the present illness? So as we know, for the history of the present illness, we always want to look at the chief complaint in as much detail as we can. And we'd like to know what the both the reason and the cause of the fall may have been. We want to know both its duration. Did this individual go to the ground for an extended period of time, or it was just a brief, just kind of lost her footing? And we want to look at things like, well, certainly the location of the incident, both in terms of the geographic. Sometimes I have patients tell me that they trip over a curb, and it's always a tripping type fall. But then also, what were the elements of the weakness? Did my ankle give out? Did the knee give out? Did the hips give out? Or was there pain associated with beforehand that caused the fall, or pain afterwards? So, the aggravating and relieving factors. What things protect you from this feeling of weakness? Is there anything you can do or not? Next slide, please. So one of the in this particular patient who's got multiple chronic conditions, what's the one key element for physical exam that you'd want to do? And you can, I guess, put in the chat box just what you would think you would want to do first, either in terms of vital signs or other types of the physical exam. Yeah, so we got blood pressure for sure. Yeah. So yeah, one of the things is that we want to do vital signs for sure. And a lot of people are saying blood pressure for sure. But not only just blood. Yeah, thank you, Rhonda. Orthostatic blood pressure. So you hit the nail on the head. So you want to have somebody that's firstly lying down, and then either sitting up or standing up to do the blood pressure check. So that's really very essential. In geriatric practice, it's essential for whether you have a fall or even not a fall. Sometimes if you just have lightheadedness or dizziness, sometimes people are totally asymptomatic and have big drops in their blood pressure. And you can see here, this red line and graph on the right shows basically from a tilt test, from going flat to upright, how the blood pressure drops and what its recovery is. And as we get older, that recovery period, this distance that you can see from the start of the drop of the blood pressure to when it normalizes or gets back to normal, can occur over several seconds, as opposed to just instantaneously. Because for younger people, they go from a supine to an upright position. Their cardiovascular system kicks in right away, and you really don't see much change in the blood pressure. Whereas in the instances with older adults, and then particularly those who are on beta blockers, where their heart rate is slowed down, right? So this woman's heart rate is likely to be quite low or slower, and she doesn't have the oomph, if you will, because of the beta blockade of the metoprolol, to make her heart beat faster and therefore increase the blood flow, in addition to her weak heart, right? So she's got several things that are contributing to a potential change in blood pressure. I see that Judy Hutchins comments about pulse oximeter, and that's a good one too. We usually like to walk the older adult for about 50 feet. Sometimes you don't need that far of a distance, and you see that all of a sudden two things may happen. One is that their oxygen saturation starts to go down. They start off at 95, 94%, and all of a sudden they're down to 90%. So you know that they're desaturating as a result of either their heart condition or lungs condition. And then the other thing that you may observe is that their heart rate starts to increase dramatically. So they may preserve their oxygenation, so the pulse ox may stay at 96% or something, but then all of a sudden you see their heart rate going from a baseline of 80 to 110. So they're really working. I mean, it's another sign of a problem. All right. So, and then we want to do some other tests. So we'll go through this, in terms of the physical exam. Next slide, please. So the question is, as I raised earlier, what is the definition of chronic disease? And so you can see that in some cases, cancer may be a chronic disease. We usually think of cancer as either being a sudden onset of something, and then people either survive or die. They're either without the cancer or not. But some people, for instance, have chronic lymphocytic leukemia. So it's a chronic cancer. It's a dwindling, type of blood disorder. We have other conditions that you can see on the list here that include diabetes, which accounts for about 15 to 20% of the population. Depression, which can also involve up to 15% of the older adult population. Anybody want to venture a guess of how much hypertension involves the older adult population? You can put it in the chat box if you wish. See who's the lucky guest today. Yeah, 65% would be a good value, and it starts off in middle age at about 65%, and it goes up to 85% by the time you're 90. So good guesses, everybody. Thank you, or maybe they weren't guesses. Maybe you had that information. But yeah, so the bottom line is that just about everybody over the age of 65 has some level of high blood pressure, whether it's stage 1 or stage 2 is another point of discussion. All right, next slide, please. So the Center for Disease Control has some definitions. They basically say there's no definitive consensus, but the key elements in chronic disease is a long-lasting medical condition, again, that goes over months and years. It can be controlled, but rarely can it be cured. It's persistent and has recurring health problems. A lot of times I liken it to a roller coaster, that some days are good and some days are not so good. And ultimately, these chronic conditions are associated with some form of disability or functional impairment. And just recall the case presentation that we had with our older adult faller. She had the problem with one functional disability, And it would be true to say, as we'll see, the more chronic conditions you are, the more functional impairments that you have. And finally, that last point there is that the vast majority of all deaths in the United States are associated with end-stage chronic conditions. Next slide, please. So we know chronic conditions by the example. So we know that things like osteoarthritis, even rheumatoid arthritis, these all can be chronic conditions, although some of the chronic conditions will come and go. Like rheumatoid arthritis can be very active for several years, and then it can burn itself out. And so that's part of the epidemiology, but it still has a chronic condition because you have joint deformities, as an example. Dementia clearly is a form of chronic conditions. And we know, for example, that the life expectancy of an Alzheimer's patient is anywhere from 9 to 12 years since its inception. Heart failure can be diastolic or systolic heart failure. And again, there's certain lifespan correlates that are associated with each of these chronic conditions. I just want to bring your attention to first I want to just say, if you don't know the names of these, chronic obstructive pulmonary disease or lung disease, and end-stage renal disease as ESRD. But I did want to bring your attention to the right-hand column there, the second from the bottom, frailty. A lot of times people don't really think of frailty as a chronic medical condition, but it in fact is. And so I just kind of challenge you to think about how you would diagnose frailty, and what are some of the elements that you would identify a patient as being frail. One of them is self-reported fatigue. Another one, which is really big, is slow gait speed. And one of my favorites is a patient encounter I was observing in the clinic hallway, where we do gait speed for our patients as part of the 4 M's. And this older patient was asking the nurse, she says, well, why are you checking my gait speed? And why are we doing this? And so the nurse said, well, we just want to get a sense of how fast you go, because if you go slow, you might have dementia, Alzheimer's. And she says, well, in that case, I better walk fast. And boy, she just tore down the hall like there was no tomorrow. But this is true. There are ways to evaluate risk factors for chronic conditions based upon our physical exam findings. So next slide, please. Yeah, so we're still talking about the epidemiology, and you can see the distribution of older adults here going from 0, the dark purple, of chronic conditions, to light purple, the 5 or more chronic conditions. And you can see what the distribution is. It's pretty evenly distributed. And so, you can just say 12% or maybe 1 out of 10 older adults have 5 or more chronic conditions. So that's huge, because what happens with multiple chronic conditions is that you often end up on multiple medications. And once you go beyond 5 medications, you know that there's with 100% certainty that there's going to be a adverse event or a drug-drug interaction. Okay, next slide, please. Oh, so this is a question I had. So if you were to survey a relative of yours, it could be parent or grandparent, and just simply ask, what the number of medications that person's taking and how many medical conditions. So what I'd like you to do is, again, maybe in the chat box here, just to for the sake of getting a depth of understanding here of everybody's connection with chronic conditions. Choose somebody that's the oldest member of your family. I mean, over the age of 65, and if you can, give an estimate of how many medications they're taking, and include vitamins, and supplements if you know that information. Yeah, so as we can see in the chat, we've got some pretty good numbers. It's like almost like a baker's dozen in some cases. So we see an interestingly a wide range. I love the 25 medications, and yeah, that's perfect. So and again, it's trying to figure out how many of those medications are aligned with multiple medical conditions. So we know, for example, the best practice for heart failure already starts off with 2 medications, an ACE inhibitor and a beta blocker. So you already got 2 on the list, so then you add other conditions like diabetes, and depending upon how well it's controlled, that can range from another 2 to 3 more medications. So again, you vary just with 1 or 2 chronic conditions, you're already rapidly approaching the zone, with which medications are going to become a problem unto themselves. And it's almost like you should say polypharmacy is a chronic condition, right? I mean, we don't say that, but that's in essence what we're thinking about. Well, thank you for everybody that put your thoughts in there about the number of medications. And as you can see, if we average this out, I don't know, we can maybe come up with some number here as to what the average is, but it's probably around 8, it looks like to me. Okay, next slide, please. Okay, so this is a big one. I was just wondering, this question: has the pandemic made management of chronic conditions worse, better, or different than before? And I think if we reflect on it, the answer would probably be worse. The issue is long COVID, which can affect up to, in some instances, 40% of the population, regardless of whether they've been hospitalized or not. Everybody thinks that long COVID was, for the people that were in the ICU or, in the hospital, but it turns out not so much. And so actually asymptomatic people with COVID can, over a period of 3 to 6 months, develop long COVID symptoms. So, it's like everybody looks at me like, why are you still wearing the mask? And I'm going like, it's I don't know how many times you need COVID to, get long COVID. That's a whole nother question. But the point being is that the pandemic has really been tough. My experience in clinic, not that I can share any data with you, but just the fact that the number of falls have increased, like multiple fallers. We used to get patients coming in that would report a fall. Now we've got patients coming in over the age of 65 with 3, 4, 5 falls, like bang, 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 all, over a period of 1 month. That's number one. Of course, we've got the cognitive issues, and that's a whole nother ball of wax to try to unravel, as to exactly how deep the cognitive impairment is. But there was a study in the United Kingdom, which is as much as the United States was hit really hard with a lot of cases of COVID. And they found that the population there, that 67%, I believe was the number, had some form of intelligence or intellectual gaps, whether it be short-term memory or the speed with which you process something. So these different spheres of brain function were found to be impaired in one domain or multiple domains. So clearly COVID's having an impact on brain function. So you can only imagine that it's what kind of impact it's having on other organs, such as the heart and kidney. Okay, so the kind of good news and bad news. This is kind of the bad news, is that over many, many years, when we have all these new medications that are coming out for chronic disease management, we're not really having much of an impact as a healthcare system on chronic diseases. And so kind of makes you wonder. So what one thing, and you can put it in the chat box, what one thing do you think would really make a big difference in terms of preventing chronic conditions? All right, Jessica, you got the quick trigger there. That's good. Yes, exercise, diet. We know, for example, with diet that the average American consumes 4.6 grams of salt a day, and we only need 2.3. And for everybody that's putting exercise, absolutely. So exercise is one of the proven interventions. In fact, I was just doing a literature review here because I'm planning to give a talk to the Memory Cafe in Fargo. So anybody that's in Fargo on this Wednesday at 1 o'clock, I'm giving a presentation there on Alzheimer's disease. But the whole point is, what is the biggest impact? And it's not medications on preventing Alzheimer's. It's not necessarily dietary supplements. It's physical activity. And the question is always, how much physical activity? Yeah, I like Robin's comment about sleep. So that certainly is true in terms of reducing stress and improving sleep. We know that to be true for cognition. And so that's now one of the fourth or fifth elements, in terms of preserving brain function. You want to reduce stress. And we know that when we're under stress, we have a lot of cortisol that, goes through our system. Cortisol causes brain atrophy. So that's another component that we want to try to consider. Well, good. Yeah. So I think everybody has a good idea. So your prescription for having an impact on chronic disease is first and foremost physical activity, and then diet is another thing that we can talk about. But just remember Mediterranean diet or the MIND diet, MIND. Okay. Next slide, please. Well, be remiss without talking about gender gaps and chronic disease. Over the course of earlier years, women tend to have more chronic conditions than men, but then as they become 65 and older, it's about gender equivalent. And there are other ramifications of gender differences. So for instance, in heart failure, the ability for the heart to recover from a heart attack associated with heart failure is different in women than in men. So there are some small differences that we don't always appreciate in terms of chronic disease, but I think that needs to be recognized as we have these different programs that we try to implement and address chronic conditions. Next slide, please. Also, we can see that there's the percent of one or more chronic conditions differs. Caucasians tend to have the highest percentage, and Hispanics have a lower percentage, like, by about, what is that, 10, 14%. There are differences amongst races and ethnic groups, in terms of the percentage. And some of this may be due to diets and to levels of physical activity. Next slide, please. Just want to point out that their chronic conditions disproportionately affect American Indian populations. And again, that just reinforces the concept that there are differences between populations that need to be addressed. Both from the epidemiology as well as the resources, right? So some populations are not as resource rich, and therefore can accumulate chronic conditions as a result of that. Next slide, please. A lot of that's called social determinants of health, and partly here's kind of a list of the risk factors. The big ones are sedentary, like this guy here. Probably that's the look on his face, as for those that watched the UND hockey game the other night, they kind of got blown out 5-2 or something. Then smoking is a big issue, and probably one of the most modifiable factors. And smoking, even smoking cessation, even in late life, still has some very good benefits. Fried foods. So one of these portions of fried turkey or fried chicken would have basically a teaspoon of salt in it. And that's already your total daily requirement for, well, actually twice that. And then finally, the right lower corner there is substance abuse, mostly alcohol consumption. All of these can contribute to chronic conditions. Age is asterisk here because age is the most highest risk factor. Just simply getting older means that you're going to develop chronic conditions, and we've already identified that as hypertension, right? That's the chronic condition that afflicts the older adult population most. Okay, next. So there are some genetic predispositions to chronic conditions. There are inherited cardiovascular conditions such as cardiac hypertrophy. It's actually much more frequent than you think. It's 1 out of 50 people. There's a phenomenon where the EKG has a prolonged what they call QT syndrome. So there's a relaxation delay, and that's can lead to a lot of times what we call sudden death episodes. And then there are some metabolic chronic conditions. So problems handling cholesterol, call that familial hyperlipidemia. There's genetic predisposition to diabetes, usually diabetes type 1. And then there are some conditions for both Alzheimer's disease and more clearly inheritable Huntington's chorea, which kind of interestingly, over each generation of Huntington's, the onset gets earlier and earlier. So the first wave of older adults or first wave of Huntington's in a family may start off and show itself in the person's 60s or 70s, but their children may have Huntington's showing up in their 40s and 50s. And then their children are going to have Huntington's show up in their 20s and 30s. So there's just something about an accelerated genetic process for that disease. It's just very, very unusual. All right, next slide, please. So just to reinforce that age is a chronic risk factor for chronic medical conditions, you can see here that the over time that the proportion of 75 and older are demonstrating higher and higher levels of chronic conditions. So it's the oldest old, you know, if you make it to your average life expectancy of 81 for women, 81 years of age, you're seeing that they can expect in their later years to have multiple chronic conditions. Okay, next slide, please. And this is just the distribution of, so in the green bar here, you can see the 1 or more chronic conditions. So by age 65, up to 90% of people can have a chronic condition. And then 2 or more chronic conditions is also increases with increasing age. Next slide. When we talk about environment as a risk factor, so these are a lot of the social determinants. And so you can see that the comparison of depression as a chronic condition, for example, for those that are in poverty is up to 30% versus not 15%. And so that right-hand column there shows the difference in diabetes, 5% more, in impoverished populations and so forth. And then on the right-hand graph here, you can see that the medication usage for lung conditions, chronic lung conditions, increases as the particulate matter increases in the neighborhood. So again, you can imagine people that live next to factories, you know, which are not high, you know, they're low rent districts, right? Relatively low rent. That those individuals are more exposed to particulate matter and fumes. And it's not a surprise that there's a higher incidence of asthma in those industrial area cities, and just if you live around, an industrial area, it doesn't necessarily have to be a city; it could be rural. Next slide, please. So just to summarize some of these things, we know that lifestyle can be both a positive or a negative, right? So if your lifestyle is sedentary, that puts you at risk for chronic medical conditions. And we know biologically that there's that these telomeres, that are the markers on the end of your chromosome, that they shrink just by sitting in front of the TV set. In fact, somebody was saying that people who watch TV after dinner have a higher incidence of hospitalization and chronic conditions than people who do something different than watching TV. They didn't really list what the activity was, but also mentioned traumatic brain injury as a risk factor for chronic conditions, as well as chronic stress and anxiety. So, the comment about sleep that Robin had put in, I think, is a good a good point. And then on the right-hand column here, of course, is the importance of physical activity, mindfulness, trying to de-stress, as well as nutrition. And I just point out here the Adventist study, which shows that people who are vegetarian forward tend to live 8 years longer than people who have just a general diet. Okay, next slide, please. Okay, so this basically looks at life expectancy. If you the older you make it to a certain age, the more likely that you're going to live to a beyond the average life expectancy. So these numbers change according to what system you look at, but basically, if you make it to age 65 and you're a male, you can expect to live to be 84-ish. And then for females, women tend to live 2 to 3 years longer. Now, the one thing that I don't show in the slide is that, while you might live longer, once you reach a certain, age, your final years of life still have a 2 to 3 year window of frailty and disability. So whether you rapidly age and, if you don't make it to the average life expectancy of, let's say, 81 for women or 78 for men, you're going to have that 2 to 3 year period of disability, whether you die young or you die old. So I hope that point is clear. Next slide, please. Yeah, so this particular table makes the difference between understanding what absolute life expectancy is and functional life expectancy. So you can see at the top here, the 70-year-old who's, let's say, independent. So they would, for women in this particular table at the top line there, you can see that their mobility disabled years would be 4 out of those 10 years. And that their functional disability, their ADL disability, will be about 2.7, right? So you can see that they basically, that there's a ability and their independence. So it's 6 years to 10 years of independence versus 6 years of dependency in some form. And that's probably why you see a lot of assisted living places being built these days, because it's in recognition with the aging population that, as described in this slide here, that a lot of individuals are going to be having either mobility or functional disability within a 5 to 6, 7 year period. Okay, next slide, please. It's a little blurry slide here, but this is a report. These vital statistics come up about every 10 years or so. And you can see that basically what it shows is that for each age cohort, going from middle age in the upper right-hand corner to 85 and older, you can see that well, for example, with the 85 and older, that heart disease is the bigger problem than cancer, whereas in the earlier years, it's cancer as a problem. So that's one of the reasons why, for example, in geriatric practices, we don't consider cancer screening as being a key component in many instances. So for example, we don't do the Pap smear after age 65 unless the individual has multiple partners, and then we don't do colon cancer screening after the age of 75, just because the life expectancy is less than 5 years and doesn't warrant cancer screening. Although now they're finding that colonoscopy is not the hot shot that it used, that everybody claimed it was. I know Blue Cross Blue Shield came out and said, you got to do your, colonoscopies. You're falling behind because of the pandemic. And then all of a sudden they come up with a study that says, colonoscopy doesn't really change the curve on death from colon cancer. So thus challenging that preventive health measure. Next slide, please. So this is an example of chronic lung disease. So you can see that the differences between life expectancy, for a non-smoker at that top line, and then as you go down to stage 3 or 4 lung disease, that their life expectancy is reduced considerably, 8.5. And you can see that a former smoker garners 3 more years of life expectancy. But that, any type of smoking during your life reduces your life expectancy as compared to somebody who never smoked, which, would have a life expectancy of 16 years, should they have idiopathic chronic lung disease. Next slide, please. This to me is a kind of an interesting figure. This came from a while back from the British Journal of Psychiatry, which showed life expectancy after the years of diagnosis. And you can see that the top line shows basically individuals who have Alzheimer's disease, that they have about a 12-year life expectancy. But if you have Alzheimer's disease with cogwheeling, it kind of looks like Parkinson's disease. Their life expectancy is shortened by 6 to 8 years. So sometimes we can use clinical observations to help guide us in terms of helping the patient as well as their family determine what remaining life expectancy is. This is an important consideration in chronic conditions because we don't have a crystal ball. It's not that accurate, but I can say unequivocally that all the research and all the studies show that both patients and their family members massively overestimate how much remaining life expectancy they are. So if somebody has heart failure and has 6 months to live, the patient and the family will always say, oh, they've got 3 to 5 years to live. It just a huge, and this is a big problem with surrogate decision makers. So a recent study came out that showed that if you're a surrogate, you always overestimate the life expectancy of the person that you're making the decision for. So if it's your mother or your grandmother, who has Alzheimer's disease, the surrogate decision maker will often say, do everything, right? Because they probably have got 4 to 5 years to live, when in fact they have less than a year to live. And that's one of the explanations why 85% of all healthcare costs are used in the final year of life. And so we really need to get in tune with this whole concept of lifespan in face of chronic conditions, so we can have a little bit better handle on using or not using acute care resources when they're futile. Next slide, please. Yeah, so here's a good example of where the observed survival is quite lower than the expected survival. And a lot of this is driven by, in heart failure, the observations were based on an echocardiogram, either progressive atrial heart enlargement or right heart valvular failure, so tricuspid regurgitation. And that's all related, as you can imagine, to how the heart swells with systolic heart failure. Next slide, please. So we know that the chronic conditions reduce functional abilities. These are the ones that we're familiar with. Just I may have mentioned in the past that the most common reason for a functional disability for admission to a nursing home by people with memory loss is due to toileting problems. So that's the most common reason why they end up in a nursing home. By contrast, people who are cognitively intact or do not have Alzheimer's, they end up in the nursing home because of this lower right-hand figure here, which is a problem with transferring. So depending upon the population and what their background is, their chronic functional impairments may be different, as a lead-in to long-term care. Next slide, please. Yeah, so this is a correlation. This slide here shows how physical limitations increase with the number of chronic conditions. I mean, this may not come as a surprise to you, but when I look at my patient list from when I go to Sanford Clinic and I look at the patient list, I just desperately try to trim it down, because every time somebody comes in with a problem, you got to put in a new problem, then it shows up on the problem list. And my gosh, these problem lists are like 25 long. You'd say, oh my God, they got 25 chronic conditions, when in fact they don't. The point being, though, is that you can see on the left-hand column here that with increasing chronic conditions, that over half that population has some physical limitations in either mobility or the ADLs. And then likewise, with the more chronic conditions, you become more socially limited. And we know that social engagement is one of those components that contributes to longevity. So that's a big difference. And then we've got some cognitive limitations here, which is also associated with. Basically one out of 4 individuals with 5 or more chronic conditions has some form of cognitive impairment. Next slide, please. Yeah, and this just reinforces the idea of on the left side there with the activities of daily living limitations, and that not surprisingly that with age there's an increase in those limitations. And then the right-hand figure there shows increase in instrumental activities, daily living, financing, house chores, shopping, and so forth, that those also increase in the older adult population. Next slide, please. Yeah, and just to reinforce the idea that if you count 5 or more chronic conditions, you really got to think about what the cognitive impairment is, because that plays a big role in whether they can self-manage, right? So I just had a patient come in, husband and wife team, and I mean, she was just sitting in a chair in the clinic booth, like not doing much of anything. It was almost like hibernating, I mean, from my point of view. And so I asked her, I said, how are you doing with your medications? I didn't get much of a response. I asked her husband, he says, I don't know. Her pill box is full all the time. Well, guess what? She wasn't taking her chronic medicine, her medicines for her chronic conditions, such as high blood pressure, and because she had cognitive impairment. Interestingly, we diagnosed normal pressure hydrocephalus on her, which was a first for this year for me. So hopefully we'll be able to do an intervention and at least reverse some of that memory loss. Next slide, please. Okay, so just to reemphasize the idea of changes in function on the y-axis, and then over time, you could superimpose this graph with mortality also. But you can see that some of these conditions, such as CHF, COPD, and end-stage renal disease, have this kind of sawtooth action where they get sick, they get acutely ill, they get functionally impaired, they recover a little bit, but not quite as much as they did before, and then they just keep having in some cases, what we call the dwindles. They just have this, progressive decline over time. Next slide, please. So we want to ask some questions, in evaluating people with chronic conditions. Some of these are, has there been a change in weight? PND is paroxysmal nocturnal dyspnea. Do they wake up in the middle of the night short-winded? Do they have racing heartbeat or palpitations, shortness of breath, swelling, leg swelling or arm swelling? And then a lot of that relates to the heart failure. And then if you ask somebody with a lung condition, is there any wheezing? Can you hear the wheezing? Sometimes people wheeze and they don't even know they're wheezing. And then also you want to ask about sputum changes and how often they use the rescue inhaler. And it never ceases to amaze me. People come in wheezing and they've got the rescue inhaler and they just never use it. How many times have you used it? Well, I don't know. I haven't used it in a while. I'm like, well, why are you wheezing? So again, patient education can make a difference. And if they don't have that insight, then you got to start thinking about cognitive impairment. You might want to do a screening test, to see if there is cognitive impairment. Next slide, please. So in terms of the physical exam, there's a couple of things that we can do. So we have, functional assessments, such as the 6-minute walk. I mentioned we do gait speed. So we always look for whether the person has 1 meter per second gait speed or less, and that's usually an indicator that there's some chronic conditions that need to be addressed. Ask the caregiver as well as the patient, about how they're doing with their function, because people tend to overestimate what they can do, or they just don't want to reveal what they can't do.